Welcome, everyone. Good afternoon. Welcome to our April CMHSR monthly seminar. My name is Leopoldo Cavazza. I'm one of the co-director of the center, along with Byron Powell. And we are very happy to have Dr. Kelly Aschbrenner to present today. She's presenting her work on peer group lifestyle intervention enhanced with mobile health for young adults with serious mental illness, results of a randomized controlled trial. Dr. Aschbrenner is an Associate Professor of Psychiatry at the Geisel School of Medicine at Dartmouth College, a Senior Scientist at the Dartmouth-Hitchcock Health System, and Director of Research at New Hampshire Hospital. Her research focuses on the development, evaluation, and implementation of evidence-based practices to improve the health and quality of life of individuals living with serious mental illness. And she uses a really unique and innovative blending of intervention research, community engagement, digital health technologies, mixed methods, and implementation science in her work. And she collaborates on numerous interdisciplinary team science projects and is dedicated to mentoring early career mental health services researcher and implementation scientist. And she's also a fellow St. Louisan. So this is always good to have people from St. Louis presenting. And I've known Kelly for many years. We do work in similar areas and really have appreciated learning from your work, Kelly, on all the great stuff that you're doing. And I'm looking forward to the results of this RCT that you've been doing and conducting over the past several years. So Kelly, whenever you're ready, you can go. Yeah.
Thank you so much, Leo. That's such a nice introduction, and I'm really excited to get to present the results from our recently completed R01 study and recently reviewed and accepted for publication study. So that's exciting too, because I'll be able to kind of throughout my talk highlight some of the things that reviewers had questions about too, which is always fun, and think about the way that we responded to them, because I think the reviews were so good of the primary outcome paper and really helps me to elevate how I'm talking about the results now. So you'll get to see some of that. So this work, just going to acknowledge some of my core teammates on this work, including John Naslund, who's an instructor at Harvard Medical School, and then my who were my senior mentors, who are now I consider my collaborators, Kim Muser and Steve Bartels, who I've been working with for a long time at Dartmouth. And then so I did this was a multi-site trial conducted in Massachusetts and New Hampshire and Connecticut with a lot of community mental health center partners and clients who participated in that research. It was funded by the National Institute of Mental Health, and our paper, it will be in press soon, and it is in press in Psychiatric Services. So hopefully you'll look out for that. So in some of the questions that I think when I look back on our study and when I read our paper and I think about the presentation, some of the guiding questions that guide me and that you may want to be thinking about as we're looking at the results are thinking about, well, why target young adults with serious mental illness with lifestyle interventions? Why are we doing that? And what are some of the challenges and opportunities for engaging young adults with serious mental illness and evidence-based lifestyle interventions? And what did we learn from this study about the effectiveness of a lifestyle intervention for addressing cardiometabolic risk among young adults with serious mental illness? And then when you look at this study and the results, what are you thinking about? What are possible next steps in this line of research that makes sense to follow up from what we've learned? So this study, we are addressing comorbid physical health conditions that contribute to increased mortality risk in people with serious mental illness. So people with serious mental illnesses, including schizophrenia, bipolar disorder, and major depressive disorders, die 10 to 20 years earlier than the general population. And this early mortality in SMI is primarily caused by cardiovascular conditions, which are largely preventable. So obesity rates are estimated as high as 60% in people with serious mental illness. Smoking rates are they're estimated between 50 and 75%. In clinic, the good news is that clinical trials have shown that lifestyle interventions can improve the health of people with serious mental illness through weight loss and fitness, even among people who are taking antipsychotic medications. So we have evidence that lifestyle intervention trials that address cardiometabolic risk factors can improve health. However, the studies that have been done have enrolled mostly middle-aged and older adults, and few young adults have participated in these trials. So that's an important point that we'll come back to in a minute. So there's clearly a need for lifestyle interventions to address cardiovascular risk in young adults with serious mental illness. There's evidence that suggests that these health risks appear early and typically go untreated in people with SMI. One of our large studies conducted on first episode psychosis, the recovery after initial schizophrenia episode, the RAISE study that was funded by NIMH, a group of researchers looked at baseline data on 394 participants who were receiving services in community-based mental health centers, and just descriptively looked at these cardiometabolic health risks. And they found in this group of young people with a mean age of 23.6 that 48% had obesity or were overweight, 56.5% had dyslipidemia, almost 40% had prehypertension, and over 50% were smokers. Another study that's looked prospectively at weight and obesity after initial admission for hospitalization for psychosis found that early overweight, so being overweight at admission, was a significant predictor of obesity. And at 20-year follow-up from first hospitalization, 50% of individuals with bipolar disorder and 62% of those with schizophrenia had obesity. So there's evidence to suggest that these risk factors are there early and people with serious mental illness, and there may be opportunity to either work on prevention or intervention earlier than middle-aged and older adulthood. So what I'm showing you here is what we in our research team refer to as the first generation of lifestyle interventions for individuals with serious mental illness. So there was a real core group, including Leo's team, I would consider him in the first generation, of researchers who were leading the way and really trying to help us think about community-based interventions that could address these health risk factors in people with serious mental illness. And so these trials use some type of health coaching principles. The format of them was different. The form they took was different, but probably their functions were very similar in these trials in terms of health coaching and trying to motivate people and support them in health behavior change that either targeted weight and or fitness. So I'm showing you here to start. You can see these were two studies that I was involved with that Steve Bartels led of the InShape health coaching intervention. And InShape is a one-on-one health mentoring intervention where the health mentor is embedded in community mental health centers, and they work with clients who have serious mental illness and try to help them with supported exercise that takes place in a gym, integrated gym-based setting. And in our two trials of InShape, we showed that it was, in the first trial, we showed that the main outcomes were twice the proportion of participants in InShape achieved clinically significant improvement in cardiorespiratory fitness. In the second trial, we found that at 12 months, InShape participants had greater reduction in weight and improved fitness compared with a fitness club only group. Another research team from Kaiser Permanente led the STRIDE study, and the STRIDE study was unique in that it only they needed to be taking an antipsychotic medication as an eligibility criteria for the study. So all of these people were taking antipsychotic medications who were enrolled in the trial. They studied a group-based exercise and diet program versus usual care. They found that the intervention participants lost 9.7 pounds more than the control group from baseline to 6 months. And then, of course, there's Gail Dommett and her team at Johns Hopkins, who have led a couple of trials. I'm showing you here their ACHIEVE trial, where the intervention was group management and exercise plus individual weight management versus health education. They found over 18 months, significantly greater weight loss in the intervention group compared to control. And then there's the PGLB, which was Leo's intervention, which involved a peer-led healthy lifestyle group intervention delivered by peer specialists versus usual care and supported housing. And Leo and his team found that the PGLB was not superior to usual care, but there were increases in the proportion of participants in both groups who achieved clinically significant weight loss from 6 to 18 months. And so, we think of these first generation lifestyle interventions. All of these studies were done in community-based settings. They were enrolling, as far as I can tell, by reading the methods and the eligibility criteria, they were open to enrolling people who were in their 20s or 30s. But when you look at who participated in these trials, the mean age is in low to mid to high 40s. So we just end up, when we offer these trials in this effectiveness research context in community-based settings, what we're ending up with is middle-aged and older adults in these trials. And so our team involved in the InShape trials were starting to think about why that might be. But it wasn't, we're building to the focus on the research, but we had been thinking about, that is really curious. Why is this happening in these community mental health settings? So what's also really interesting is that when you search the literature for what we know about young people with serious mental illness and really what their preferences, their values, their interests in health might be, especially the health behaviors in their potential interest in interventions, there's really not a lot in the literature, in the published literature. And what we found was that there is actually, so in the general population literature on behavioral weight management, they also have challenges recruiting young people in effectiveness trials that are offered out of diabetes clinics or weight management clinics in hospital settings or outpatient settings. They have a challenge recruiting young people in those studies. So Jessica LaRose and her colleagues have really carved out, she became very interested in young people. So these aren't young people with serious mental illness necessarily. These are young people in the general population and trying to learn about their preferences and values and interests in lifestyle interventions. And so some of what Jessica has found, she's found that young people, when it comes to their interests, it's really not necessarily weight loss, isn't like the central motivation, but they're interested in, talking about self-improvement. They're interested in fitness. And when it comes to what types of interventions they prefer, she's found they prefer a low intensity program, something that involves some technology, peer coaching, experiential learning, potentially peer support. And what's really important is that young people feel like they're given autonomy and choice in whatever it is you're offering to them. She also found in the National Weight Control Registry, which is a database of people who have successfully lost weight and have enrolled in this registry to be surveyed and interviewed about their experiences with weight loss maintenance and motivations and all types of other interesting related factors. She found that young adults in that registry are more likely to express appearance and social motivations for weight loss. They're less motivated by future health consequences, which kind of makes sense. If it's going to be 20 years before, chronic health conditions really impair their life, it's not something they're thinking about immediately. And they're also less likely to report a medical trigger for weight loss than an older person might. So an older person might be more triggered because of some issue related to their heart or some event that has happened that has caused them to want to lose weight. And young adults are more likely to use exercise classes and to lose weight on their own and less likely to use a commercial program. So the things we learn about young adults, the things that we know that are in the research literature, have primarily focused on young adults in general. There's not a lot known about young adults with serious mental illness and they're interested in health and health behavior change. So as our group had been, we'd been pursuing some pilot research that was adapted from our InShape trials. This pilot research was underway, and at the time that we were close to finishing 2 of our pilot studies, the NIMH released an FOA that was focused on improving health and reducing cardiometabolic risk in youth with serious emotional disturbances and young adults with severe mental illness. And if you're not familiar with how these FOAs sometimes work, this was posted on August 6th, and the due date was November 3rd. So it was like and then by the time you meet with your research team and you work with your authors of sponsored projects, that window grows really small. And our team was thinking about, we didn't have at the time we didn't have much experience with young adults in our lifestyle intervention research. Our research was not, it was what I showed you before. It was in community mental health settings. It was all comers, anyone who was interested in enrolling. We didn't have young adult specific research experience at the time. But we had been doing pilot work, which I'll show you in a minute, that we really thought had these qualities that a young person might be interested in, might be beneficial for young people based on what we know from the research I just kind of went over from the general population. And we thought we had something that could be potentially appealing to young people, and that we should apply and see if we could evaluate this in this RFA and see what happens. So this was my first R01. We wrote it in probably a month and a half, and it was funded. I think they funded 4 of these responded to this RFA, and it was a one-time set aside. So it was like they selected 4 studies and then we moved forward. So I'm going to tell you about what made us think that we had any intervention that may be useful or appealing to young adults, and most importantly, beneficial to them. And why did we go for this R01? So at the time that RFA came out, our team had been studying the PeerFit group lifestyle intervention in community mental health settings. So PeerFit is a weekly weight management exercise group program. It's led by a professional trained in coaching techniques. So it's not different from Leo's intervention. It's not led by peer support specialists. It's led by a coach. But the focus is really on building peer-to-peer support. So the idea was to take some of the didactic curriculum, including some of the curriculum of the diabetes prevention program. Some of those curriculums are really about teaching people, talking at them, telling them, what could be helpful to them if they want to make a behavior change. And we did pilot it. We piloted the diabetes prevention program in a community mental health center the way it was intended, with the dietitian, with the whole, dietary tracking structured curriculum, and it failed miserably. I think half of the people just didn't come back. And it was just, we learned a lot from that pilot. And we learned a lot about the potential, though, of that material, because it's good information. It's just the way that it's presented, we thought could be improved. And especially we felt like those didactic curriculums weren't really leveraging the group experience. So people being there, people who sign up for interventions like this, generally are people who are comfortable being in a group, who feel like they might benefit from a group. And so we worked really hard in our adapted, the way we modified the curriculum to try to create more experiential peer-to-peer sharing and learning in the sessions. And it was guided by social learning theory, including, the idea of observing and modeling behaviors of others. And we used popular technology to support behavior change. And this is, the technology piece is really part of why we thought we would also have a program that would be appealing to young people. We used wearables. So in addition to the twice weekly group sessions, one focusing on lifestyle, health behavior change, and the second focusing on exercise, led by a fitness trainer, we enhanced that with technology. Specifically, we used Fitbits. So participants had wearable activity trackers. They had text message reminders from from the coach to promote program engagement and attendance and support their lifestyle goals. And then we had a private Facebook group where if you were in this in-person group, you could go on to the private Facebook group. And the idea would be you could meet other people who are in the group, you could communicate, you could support each other, you could interact with the coach. So we piloted the peer fit intervention twice in 2 small trials in Community Mental Health Center. We had some promising findings for the pilot, especially around feasibility and acceptability. And we had been finishing this pilot work when that RFA came out and responded and proposed to evaluate peer fit, the effectiveness of peer fit enhanced with technology for young adults with serious mental illness in community mental health settings. And we made some minor modifications to the peer fit curriculum to make sure it was tailored enough for young people. And I really want to emphasize those modifications were to the form. So for some of the activities, for example, we have an activity that's this experiential learning where we use what we used to use in my family was we call them circulars or flyers, those printed ads for the grocery store. We would look at the ads and think about what we wanted to, things that were on sale, but that really wasn't as appealing to young people as downloading the app from the grocery store, from, the Schnucks grocery store or something that they could then look at the sales. And so we did those are the types of modifications we made to the curriculum. We didn't change the function of peer fit, which was to support health behavior change through supported health coaching and experiential learning and peer-to-peer support when we made the modifications. So we conducted a 12-month study where we enrolled 150 young adults who had a BMI of equal to or greater than 25. And we compared peer fit to our comparison condition was mobile intervention with basic education and activity tracking. So we wanted to do, with the comparison condition, we took out all of the group element. So there was no interaction with other people in that, who were randomized to that arm. You were only interacting with the coach, and you only met the coach once in person. Every other interaction was through phone coaching and text messaging, and that group also had a wearable activity tracker. So we were trying to, as much as you can, try to isolate the group part of the peer fit intervention in our trial. Oh, here's our team, and all of us who are involved in these big projects know how much work it takes to pull them off, and all the community partners you have, along with the research staff and other external partners throughout the trial. So this is our Fit Forward study team. As far as the methods for this trial, this was a 2-arm randomized controlled trial conducted at 4 community mental health centers. The randomization was stratified by site, birth, sex, and psychiatric diagnosis. Research staff collected data at baseline, 6 months and 12 months. And our main outcomes were clinically significant changes from baseline in weight, cardiorespiratory fitness, which is an increase of 50 meters or more on the 6-minute walk test, which is a submaximal exercise test of aerobic capacity. And then cardiovascular disease risk reduction, which is this measure that our group has used in the InShape trials. And I know Leo and his team has also used this, where you combine, it's either or, it's clinically significant weight loss or improvement in fitness. And then we added an exploratory analysis of weight gain prevention. And we did so because if you look at the general population literature, a lot of studies for young adults, their primary outcome is weight gain prevention. And, they argue that it's because in young adulthood, that's the time in life when you're most likely to gain the most significant amount of weight in a given period. There are a lot of changes during young adulthood because of moves to college, pregnancies, all kinds of reasons why people gain weight in that period, maybe not being as active as they used to. And so a lot of the actual behavioral weight management interventions in the general population focus on weight gain prevention. So we added that as an exploratory outcome. So a little more about our study interventions. This was our peer fit groups. Again, we had twice weekly 1-hour group sessions. Should mention that we did twice weekly group sessions during the intensive phase, which was the first 6 months of the trial. And then after 6 months, between month 7 and 12, we offered 1 group session a week, and that was for exercise. And then, of course, that was enhanced with text messaging, and the coach provided reminders, encouragement, and motivation. And we built a text message library bank with text message examples that are aligned with these theoretical domains of health behavior change. So we had a bank that had examples of text messages supporting self-efficacy. We had a bank that was supporting self-monitoring. So some evidence-based techniques that we use in behavioral weight loss, those were kind of the focus of some of the texts that were around motivation and encouragement. And then we had our Facebook group. So the lifestyle coach moderated the group with 3 to 5 posts per week. And we had used some engagement strategies to frame the posts that they were given. It reinforced content during group sessions. They tried to encourage peer-to-peer interaction and support and help participants stay connected outside of the group sessions. So the BEAT intervention, our comparison condition, this involved 1 in-person orientation. This was one of our coaches where you can see her here, a client would be coming and meeting with her. She'd be going over the technology, she'd be going over the goals of the program, and just really get a chance to see each other in person before the remainder of their time, which involved 5 monthly coaching calls using a curriculum that we designed for the coaching calls, structured curriculum that she used, and then 3 to 5 text messages per week. So similar to the text that the peer fit coach was given, they were focused on encouragement, motivation, and then the participants also had a Fitbit to encourage tracking of their physical activity. So here's some details about our AIM and our aims and analytical approach for the aims. So here is here's where I tell you a little bit about our response to reviewers, which is, I think, really important. I want to make sure when I give this presentation, I get to emphasize this. So this was our consort diagram, which shows you the flow of participants through the trial. And you can see, we assess participants at 6 and 12 months, and you can see what the retention rates look like. 83% is pretty, if you look at published studies of psychosocial interventions for people with serious mental illness in the community, 83% is about on par with what you see from those trials. At 12 months, retention was 69%. And having lived through this trial and having observed these young adults being in the changes that they go through in their own life over a 12-month period, and the challenges that they have, 69% to me actually felt pretty good compared to how it seemed when we were going through this study. It felt like that is realistic, and this is what happens when young people who are enrolled in community mental health services, when they're experiencing a lot of things they experience where they're in and out of care, be outside of our treatment, they were in and out of services. They had things go on like moves or challenges with their families, just other things related to social determinants of health. So I actually thought that was a pretty reasonable rate. But again, the reviewers, I think some were more critical than others, but it gave me an opportunity to not only explain what young adulthood may be like for a young person with serious mental illness, but also reference what I could, the trials, like I mentioned the RAISE study before, which is a study in community mental health and young people with serious mental illness, and their retention rate was even lower. So I was able to compare to some of the few other trials we have with young people with severe mental illness and psychosocial interventions. So I think, engagement is important. Helping people stay in these studies if they want to is important. But I think this is also a challenge for the field when it comes to engagement overall and in general for us to think about. Okay, so here are of the 150 young people we enrolled, their mean age turned out to be around 28. The mean body mass index was 37. Some other notable points here, we had 43% of participants had a psychotic disorder, and 71% were taking an antipsychotic medication, and 39% were smoking at the time of the study. And another notable, I think, baseline, some data to show you, we had 30% of participants had a BMI of 40 or higher. 40 is a severe or morbid obesity, and often candidates, people with a BMI over 40 are candidates for bariatric surgery. And again, if you look at the behavioral weight management trials in the general population, just take a careful look at their eligibility criteria. Often, if you have a BMI over 40, you're not enrolled in those trials. So they're not even usually included in research. We had someone with a BMI of 68. So our range was 25 to 68. We checked it. We triple checked it. It was accurate. But it also told us, we felt like this was positive news. It told us that in a community mental health setting, so the referrals were coming from the providers, the referrals were coming from the staff on site. And we thought, they're really helping to find the clients who may actually be benefiting the most from enrolling in these studies. So we thought that was also encouraging that they were including people with high BMIs in the study. Okay, main outcome results. So here it is. So we can see here, what I'm showing you are the proportion of participants who are achieving clinically significant weight loss, improvements in cardiorespiratory fitness and cardiovascular risk reduction at 6 months and 12 months follow-up. And I'm showing you the between groups and over time within group results. So you can see that there were no group differences were observed in the proportion of participants who achieved clinically significant changes from baseline in cardiovascular risk, weight, or the combined measure of cardiovascular risk reduction at 6 or 12 months. So similar to Leo in this team, no differences between peer fit, the group-based intervention, and BEAT, the one-on-one remote technology intervention. We found, though, a significant proportion of participants in both groups achieved clinically significant weight loss, cardiorespiratory fitness, and cardiovascular disease reduction, risk reduction from baseline to 6 months. So no between group differences, but within group differences were significant at 6 and 12 months. So I'm just showing you, I think it's helpful to see the data plotted out too. So I want to show you here the % change in clinically significant weight loss over time according to group. So again, there's no significant differences for the group, but you can see that the BEAT, which is the technology intervention arm, our comparison condition, you can see we had a 25% of participants had a clinically significant weight loss over time. And in PeerFit, it was somewhere around 13%, so a little lower. And here is the fitness, clinically, the change, % change in clinically significant fitness over time according to group. And, you know, PeerFit had that in-person session for exercise. So it makes sense that it would be a little higher in terms of the fitness at 6 months. You can see that it went down at 12 months, and that I'll show you the attendance data in a minute, and we'll may explain why, although may not. So here's the % change in cardiovascular risk reduction over time according to study group. So we had about in both groups, 30% of participants achieved cardiovascular risk reduction at 6 months. And so here's the exploratory analysis we did, looking at % of participants at or below baseline weight by study group. So you can see at 6 months in both groups, over 50% of participants, there was no change from their baseline weight in terms of gain. So they didn't gain any weight. This was the weight gain prevention. It was closer to 58% in BEAT, and still at 12 months, it was 50% in PeerFit and a little higher, like 53% in BEAT. So now we're gonna look at the intervention coaching session attendance. I think this helps to unpack it and tell more of the story of what happened in these interventions. So our attendance, it was very low. It was very poor in the PeerFit intervention. So you can see here the weekly, I'm showing you the weekly group lifestyle sessions. So the mean attendance was 6.3 out of 24. The weekly group exercise sessions was about 5.5 out of 24. And then we looked at, was curious, what percentage attended at least one session in PeerFit. So 70% came to at least one of the lifestyle sessions, and 75% attended at least one exercise sessions. And as I mentioned before, when we were looking at the fitness data at 12 months, you can see during the maintenance phase, which was between months 7 and 12, that 52% attended at least one exercise session. So just a little over half came to just one, and they didn't come to very many if they came to one. So if you look at the BEAT condition, which was the one-on-one remote coaching intervention, I thought, okay, well, we'll probably if you're at least looking at how many came to at least one session, it's probably going to be similar in these two conditions, because they both had to come, they both had to show up, they both had to come to the mental health center and meet with a coach. And you can see here that the BEAT, the percent that attended at least one session, was 97%. So the participants randomized to that arm, 97% showed up for that in-person coaching session. And then their mean attendance in those coaching calls was 4 out of 6 of the coaching call sessions. So then, we're curious, well, what is it, what's the relationship anyway between if they're attending these sessions and the outcome? And we found with PeerFit, there was no significant relationship between session attendance and outcomes. With the BEAT session attendance, those were the monthly coaching calls, we found a significant association between participation attending the coaching calls and the 5% weight loss outcome. So what does this all mean? What are we making of the results? So we can see from these results that the peer group intervention was not superior to one-on-one mobile health coaching in achieving clinically significant weight loss, cardiorespiratory fitness, and cardiovascular risk reduction. Both interventions improved outcomes. Weight loss outcomes were stronger than fitness. Weight gain was prevented in over 50% of participants in both of the interventions. And engagement was a challenge for the in-person intervention, but not for the low-touch, low-intensity mobile health coaching comparison condition. So I guess, thinking about one of our primary conclusions, it would be that the low intensity mobile health coaching just may be a scalable and effective intervention for addressing cardiovascular disease risk in young people with serious mental illness in community mental health settings. I have to say that even anecdotally, supervising the coaches in that arm, so the mobile health coaches who were doing the text messaging with participants and having these coaching calls, it was a much, because the participants were engaged, I think it was just a much more enjoyable experience for the coaches, for our team, for, to deliver that intervention, where participants seem to be at least, coming to the coaching calls and engaged in the coaching calls and texting with them, compared to PeerFit, where a lot of our time was spent on engagement. And a lot of the engagement often it had to do with things that were outside of motivation for health behavior change. Often the coach, who was meant to be a health coach, was trying to help the person, figure out things like, well, if my brother took the car for 3 weeks and now I have to take the bus, but I don't know how, I don't take the bus very often. I don't like the bus. How am I going to get there? Things like, moving to a new apartment and missing a few sessions and feeling like you don't want to come now because you're already 3 sessions behind this exercise group. And there were a lot of things that we were, challenges that participants had that seemed to be beyond just what we were really wanting to help them with was the health behavior change piece. And so I think we learned a lot about, the challenge of having these intensive in-person group interventions for young people who are in community mental health settings. And there may be other ways to do it. There may be ways to time it so that they're more convenient, perhaps for participants, if there's a reason, if there's a desire to try to think about how you could have an intensive in-person lifestyle interventions for young people, there may be other ways to do it. I feel like for our team, we really felt pretty strongly at the end that that having at least something that's really hybrid with mobile coaching for young people could be quite convenient and accessible to them. And we have right now, we're, as I mentioned, this paper, the primary outcome paper results are in press, and our team is right now working through a mixed methods analysis where we interviewed a subgroup of participants in both PeerFit and BEAT and stratified them by high and low engagers in the interventions. And we're really trying to learn from participants what they thought was feasible and acceptable and desirable about those 2 interventions arm, and how that can help inform the future intervention work we do. And so thinking back to the guiding questions about why target young adults with serious mental illness. Well, there clearly a lot of health risks for people with serious mental illness, especially as they get into middle and older age. And so there's a compelling reason to design prevention and interventions that target young people. However, we know that some of the challenges in doing this may especially be around engagement and the things that a younger person, the things that they may be challenged with in life during that stage. And then opportunities for engaging them may be around leveraging technology, and especially technologies that are popular and that they're comfortable with and they're familiar with using to deliver evidence-based lifestyle interventions. And we learned that both that not a peer group wasn't superior to technology, that they can both be beneficial in terms of changes in weight loss and fitness and cardiovascular risk reduction and weight gain prevention as well. And then the possible next steps in this line of research, I think we have some thoughts, but just for the purposes of time, I'm going to open it. I think I'm going to conclude and open it up for discussion because I'm very interested in hearing all of your thoughts about these things and as well, and questions you may have.
Awesome. Thank you, Kelly. This has been great. So first of all, you made me feel old today by putting me in the group with Bartel and Domit and the whole group. I don't feel myself part of that club, but thank you for doing that. That was actually pretty cool. But totally understand. Our project definitely is a sort of middle-age groups and stuff like that. So I guess questions that people have for the group. I have a bunch of questions, but I would love to hear more from other people. So there's a question in the chat from William. Hi, William. Given your experience how did you handle folks without access to reliable technology, given sort of the aspect? And then also, other than engagement, what could you potentially explain the high spike in outcomes at 6 months and then a significant decline at 12 months? Yes, those two. So technology and the changes in outcome between 6 and 12 months.
Yeah, we had through our trial, we had funding to provide mobile phones if people needed them, but there weren't many. It's probably 20% of people, or even lower, that we ended up buying mobile phones for through the study. There are a lot of young people in community mental health do have smartphones. Often we would hear people would have a smartphone before they'd pay their rent because it was so important to them to have it. That really wasn't a challenge. We did budget for it, and we budgeted quite a bit for it. At the beginning of this trial, we wrote this study in 2015, the grant for this study. So at that time, we did have a big budget for mobile phones, but that didn't turn out to be a major challenge for us in this study. In terms of the outcomes, if you're talking about the fitness outcome, the attendance was lower in the phase that was between 7 and 12 months, which, it's hard to it's a long time, first of all, to be in an intervention 12 months. That's a really long time for any of us to be in a program. And I think especially when you have these programs that do any type of transition or stepping down, where it's like, we're doing twice weekly for 6 months, and now we're gonna, only have one group session. I think a lot of people felt like they had graduated, they were done, they had their outcome assessment, and they maybe moved on. I think, as I said earlier too, I think it's really important for the next trial that's focused on young people with serious mental illness and health to also track life experiences or life events or social determinants of health, or because that's a whole part of the picture here that we're not really seeing. Is well, at the same time they were trying to change health behaviors, engage in a lifestyle intervention, they were also losing their housing. They were also having more, it's a time, if you have a serious mental illness, your psychiatric symptoms may be more unstable than when you're 45 for many reasons. And so they're also dealing with fluctuations in their mental health. So there are a lot of things that I think over the course of a year makes it challenging for people to stay maintained and be able to benefit from these interventions.
Cool. And there's a question from Mustafa regarding how diverse were the participants and the location, whether this research done in urban, rural area, or a combination of
Yeah, so we did, one of our sites was in Boston. It was at Massachusetts Mental Health Center, which is in the heart, community mental health center, like in Boston. Another was in outside of Hartford, Connecticut. So it was a pretty diverse group there. And then in Manchester, New Hampshire, which is our most diverse city in New Hampshire. And then the other one was Nashua, New Hampshire. So they weren't rural. They were all urban, in a big urban place, Boston, and the other one outside of Hartford and New Britain, Connecticut.
You know, our team is working on understanding the moderators of treatments, like who did this work best. And actually, we have one finding that the younger, and ours are 49 and below is what we're calling younger, given our sample size, tended to have benefited most from PGLB rather than usual care, even when both of those groups. But I wonder, as you're looking at your mixed method, is that one of the questions you're asking, like who responded best for this intervention? Because there is some variability here. Everyone seems to be improving, but is there a particular group of people, either clinical characteristics or personal characteristics or other, that seem to have worked best here for them, Kelly?
Yeah, we're planning our secondary analysis now, and we're not, so I don't have an answer for you of who worked best, who it worked best for. It'll be very interesting to look at those things, though. We of course collected mechanism, we collect our hypothesized mechanisms were peer support and self-efficacy. So I think that in terms of engagement, there was a subgroup. So like 30% lived with their parents. And we also have data on not just peer support, but general social support. And we have data on parental contact. So for peer fit, it looks like we've been looking at those variables in the relationship to engagement. It looks like the people who had a diagnosis of psychosis and lived at home or had real frequent, like weekly contact with parents, those people were the most engaged in the group sessions. And it anecdotally, I think also makes sense. They lived with caring with parents who wanted to, they were connected enough to the community mental health center for someone to tell them about this program and for them to feel invested in wanting to help their son or daughter engage and bringing them to the program. We had one of our groups was held at a senior center in the community. Our young adult group was held at a senior center, and one of the dads was like going to the senior center when he would drop for some bingo or some activity, when he would drop his daughter off for these afternoon sessions. So there may be with this group also, I think, we're thinking about family and the role that could play in helping with engagement. And then also if you're living with family, of course,
right,
what the environment that they could provide that could potentially support your desire to make health behaviors could probably make a difference. So if I were going to, when we start looking at the data, that's the area I think really important to explore in terms of outcomes.
Makes sense. And Kathleen, you have a question in the chat. You mind unmuting?
Oh, yeah. I was just asking about whether you took medications into account when analyzing the outcomes, specifically in regard to antipsychotic-induced weight gain.
They're not antipsychotic. So taking an antipsychotic isn't associated with any of the outcomes. Just having taken an antipsychotic, it's not associated with the outcomes here. And I think the thing with antipsychotic medications, and in SHAPE, I worked with several psychiatrists who had some junior psychiatrists who were very interested in the medication data. The thing is, I think you have to catch that right at the, because you're not continually gaining weight on most antipsychotics. There's a period of time, like, a window where you're gaining the most amount of weight and it's the toughest. So I think if you did a study where you wanted to look at weight gain prevention of people taking antipsychotics, it would probably be smart to target your weight gain prevention efforts at a time closest to when they're getting prescribed these new. So in first episode psychosis, for example, when people are newly prescribed these medications but they also may have health behaviors that are contributing to that experience of weight gain, that might be a good time to really target a lifestyle intervention. I think, we know that antipsychotics, you can still lose weight on antipsychotics. The weight gain prevention, I think you have to think about timing that, right, is my impression of how that could be most beneficial.
And Michael, you had your hand raised. We'll take one more question. Be great.
First of all, thank you so much for this sharing this great study. So it seems that control conditions were also beneficial in health outcomes. And there seems some like healthy lifestyle coaching or exercise coaching apps out there in the commercial market. Were there any participants who used these apps at the same time, or at least much more comfortable with this type of strategy or intervention that could potentially influence?
Yeah. So there were people who talked about using some fitness apps, I think, with their coaches. I work with smoking cessation researchers who are trying to figure out the app, trying to really understand if apps could work, how they could work with people with serious mental illness. I have to say that the engagement piece, like talking to in our study, the chance to talk to a coach, the chance to get a person, they weren't automated, it was a human, texting supportive messages. In our qualitative data, that is something we're hearing about from participants in that trial that was meaningful to them, that having the coach on the other end. I think with apps, the challenge is often engagement and sustained engagement. So people will, may in the beginning engage in their app, use their app, but they're challenging when they're standalone and they don't have any engagement or outreach efforts outside of the app. People just, people without serious mental illness, most of us it's easy to become disengaged with an app. So what I'm learning from my colleagues who are doing that work in smoking cessation is like, they're thinking about how do you pair that app with a coach who keeps keeps the engagement in the app going, so that you may be delivering the evidence-based content in an app, but that's paired with a coach who's like doing the things similar to what we were doing in our, around engagement and the coaching in the comparison condition. And by the way, I learned a lot about, not calling it a control condition and a comparison condition too through the trial, which is something we didn't think much about prior to this trial, but the language, like this was a comparison condition. This turned out to be a comparison condition, right? Not a true control.
Yeah. You are delivering some element of intervention here from both groups. So Kelly, I want to thank you so much for your time and for your great work. Thank you, everyone. Our next session will be May 26th at 4 p.m. and we'll have Dr. Adrián Aguilera from UC Berkeley presenting digital health interventions for depression and diabetes in underserved population and the work that he's doing. So Kelly, thank you so much for your time, and thank you everyone for being here.
Yeah, thank you all.